Good afternoon. My name is Christina Coltrane. I'm one of the members of this Quality Improvement Project, along with Josie Hodge, Harrison Whitaker, and Kiara Ferguson. And our topic is focused on reducing heart failure readmission rates. Heart failure is one of the leading causes of 30-day hospital readmissions, and this is problematic because it can lead to poor patient outcomes, increased risk of healthcare-acquired infections, increased workload on the healthcare staff, and increased costs. Some of the following factors that can influence these rates are poor nutrition, ineffective initial treatment, and poor discharge planning and education. So some of our nursing interventions that we implemented in the project address some of these factors. Next, with our business case, nearly $31 billion are spent on treating heart failure cases annually, and this accounts for inpatient hospital stays, invasive medical devices and treatments, and substantial medication use. And in addition to these healthcare costs, back in 2020, about $12 billion was the total loss of earnings due to morbidity and mortality of heart failure cases. So adequate resources need to be allocated for this project in order to address this issue up front to potentially reduce healthcare costs, societal losses, and lead to better management of the disease process. Reducing heart failure readmission is also a priority quality measure according to the CMS, and therefore our target hospital can become eligible for reimbursement incentives. These are our two primary aims of the project. So our target location is Atrium Health Wake Forest Baptist in Winston-Salem, and they have a current readmission rate of about 19.2%. So our goal is to reduce that rate within a year to about 12 to 18, or by 12 to 18%, and then within 6 months, reduce it by 15%. And our goals highlight post-discharge follow-up, personalized exercise plans, and dietary counseling as key strategies to improve patient care and education, foster treatment plan adherence, enhance communication and coordination.
As Christina previously mentioned, the current Atrium Health Wake Forest Baptist readmission rate is 19.2% for heart failure patients based on around 300 people. So we calculated our expense budget cost on providing care for 300 patients, averaging a 5-day hospital stay. On the left is a breakdown of what it would cost for each action step, and then on the right you can see our overall cost came to a little under 10,300 per patient and a little over 3 million for all 300 patients.
As far as our project structure and management goes, when it comes to oversight and structure, we are looking at a dedicated heart failure readmission reduction task force at Atrium Health Wake Forest. This will consist of cardiologists, NPs, CMs, registered dietitians, PTs, social workers, and especially our IT department as we move into our post-discharge follow-ups. We're definitely going to be looking at data, and we're going to have data-driven methods to lower our readmission rates. When it comes to governance and operational framework, we're looking at operating beneath hospital's current quality and patient safety committee. We'll have a designated QI coordinator who will oversee the project and implementation, track performance, all that great stuff. But when it comes down to nursing frontline, the brass tacks, we're going to need nurses, LPNs, RNs, CNAs, helping educate clients on management of heart failure, discharge planning, and adherence to medications post-discharge. And we hope to have our task force convene bi-weekly or at least monthly to tackle any issues that may arise. As far as the institution and support and resources that we need from them, from Baptist administration, definitely going to need support for IT assistance as far as our telehealth appointments go and for data collection and training, whatever modules may be required there. Ongoing workshops to educate our staff on optimal heart failure management techniques, as well as our client population. We'll definitely bring in some external consultants if necessary to help enhance any sort of training, evaluation, management that we may encounter during a patient admission. Leadership is going to be super vital here. We hope that hospital administration will help us obtain financing and implement policy modifications as we move forward. There are also frequent visits from hospital leadership administration will help foster improvement and a community that really seeks to help decrease heart failure readmission rates based on our evidence-based strategies and ongoing involvement from our team locally in whatever unit we're discussing. This is hospital-wide, and especially from our management hospital administration roles. And definitely successful QI initiatives will be determined by our QI improvement team and executive leaders with the implementation from frontline personnel and their involvement as well, their recommendations that they have given to us.
As for our evaluation metrics, the primary evaluation metric that we will be using for our proposal is the rate of readmission within 30 days for patients with heart failure. And on the right is just a breakdown of how we determined that rate. In order to complete this evaluation, data will be assessed by IT on a monthly basis to monitor the program's progress, and this will allow us to make necessary enhancements and will also allow us to evaluate the success of the implemented interventions. Continuing on with that, as just previously mentioned, the importance of this metric is that it will gauge success of our interventions within this patient population. And the areas that we are evaluating are medication compliance, patient instruction, remote health tracking, exercise programs, and dietary assistance. And evaluating these areas will allow us to make data-supported modifications to improve patient results and optimize resources with the help of many staff.
One of the biggest benefits of these proposals is workload reduction and efficiency for nurses. Fewer readmissions means there's less time spent on the lengthy admission process, which allows nurses to focus more on patient care and emphasizes prevention rather than having to constantly manage avoidable complications. With better discharge planning, patient flow improves, reducing delays and easing strains on staff. Beyond that, these changes create significant professional growth opportunities for nurses. Stronger protocols help nurses gain valuable skills in telehealth, patient education, and discharge planning, all of which are becoming more relevant and essential in healthcare. There is more room for leadership roles, particularly in quality improvement, giving nurses a stronger voice in decision making. Additionally, working closer with interdisciplinary teams would help build stronger professional relationships, potentially opening doors for career advancements. Finally, these proposals offer financial and organizational advantages. So lower readmission rates boost hospital performance scores, leading to better funding and resources for nurses. Cost savings could also mean improved staff ratios, reducing burnout and errors. And since nurses spend most of their time directly with patients, their role in preventing readmissions really reinforces their value, building a strong case for promotions, bonuses, or other financial incentives.
As for the factors that we will utilize to implement this plan successfully, we have initial data acquisition that will identify high-risk heart failure patients using EMR data that will be acquired by clinical data analysts. The development of our program, so we will develop standardized heart failure discharge checklists, medication reconciliation and adherence, client education, and a follow-up schedule. The continuity of our program looks like scheduling early follow-up visits within a 7-day post-discharge, just to evaluate how they are progressing. As for client education, this will be strongly focused on heart failure management. So we will provide clear and written and verbal instructions on diets, medication adherence, symptom monitoring, and lifestyle changes. As for mobility planning, with the help of PT and OT, we will develop and implement mobility and recovery plans to improve strength and their ADLs while reducing any mobility complications they may be experiencing. As for medication compliance, we will enhance our medication reconciliation at discharge, and this will be helpful in preventing any contraindications and possible complications that they will experience from that. As for follow-up, with the help of case management and social work, we will develop and implement telehealth monitoring for high-risk clients to track any of their symptoms and how they're working with medication adherence. And lastly, our evaluation and modification. We will do this at least on a monthly basis, and we will reassess that those heart failure readmission rates, the utilization of the interventions that we have implemented, and hold quality improvement meetings to discuss our progress.
These are the references that we use for our information, and thank you for your time, and we look forward to your feedback.